morning, I'm Dr. Mary-Carmen Amigo, and I would like to thank the organizers, especially Dr. Paula Alba and Dr. Ponce Estel, for inviting me to participate in this session. I'm going to talk about quality of life in antiphospholipid syndrome patients. Quality of life, according to the World Health Organization, is the individual's perception of their position in life in the context of the cultural and value systems in which they live and in relation to their goals, expectations, standards, and concerns. So this is a multidimensional concept. This is different from health-related quality of life because this one includes physical and mental health perceptions and their correlates, including health risks and conditions, functional status, social support, and socioeconomic status. The concept of health-related quality of life overlaps with the concept of health and also with quality of life, and this may lead to confusion. Health-related quality of life can be used to mean just the way health affects quality of life. The antiphospholipid syndrome is a chronic autoimmune condition that affects young patients in the most productive years of their lives, and the consequences of damage secondary to APS involve a decrease in health-related quality of life, as I am going to show during my talk. Among the instruments to measure health-related quality of life in APS, we have generic instruments, and the most common are the Medical Outcomes Survey, short form 36, with 8 dimensions, and the Euro Quality of Life with 5 dimensions. There is no one instrument specific for APS, and some studies have used the Lupus Quality of Life Questionnaire. It is important to measure the quality of life regarding the anticoagulation therapy, and the Duke Anticoagulation Satisfaction Scale has the potential to help identify reasons for dissatisfaction and also the positive satisfaction of patients who are well anticoagulated. Here you have the 5 studies that specifically address health-related quality of life in APS. And in all these studies, the short form 36 was used, and in one of them, also the lupus quality of life. These studies included patients with a primary APS, secondary APS, systemic lupus, and asymptomatic individuals with antiphospholipid antibodies. In the first 3 studies listed in this slide, the main objective of the study was not to address health-related quality of life. However, they measure this health-related quality of life with the short form 36 in one case, and with the Euro Quality of Life 5 dimensions in the other 2 studies. The study by Medina and collaborators is a long-term follow-up study that assess organ damage and health-related quality of life in primary APS patients. So the results from these studies have consistently shown that primary APS patients and also secondary APS patients had impaired health-related quality of life compared with controls, and women were more impaired. Most SF36 dimensions are lower in secondary APS compared with primary. Arterial and venous thrombosis impact health-related quality of life, especially if myocardial infarction, a stroke, or pulmonary embolism are present. Patients with arterial thrombosis had more repercussions, and health-related quality of life in one study showed that was poor in primary APS, mainly affected by BKA therapy, anticoagulation therapy with vitamin K antagonists. What about organ damage and health-related quality of life in PAPS? This is the long-term follow-up study, the only one that is long-term, and they included 67 patients with a mean follow-up of 15 years. DVT was present in 72% of the patients, with pulmonary embolism in 36%, and the stroke was evident in 1/3 of the patients. Organ damage was documented in 98.5%. Damage assessed by the Damage Index APS instrument showed involvement of neuropsychiatric and peripheral vascular domains among the rest of the domains, and organ damage correlated inversely with all SF36 domains, significantly with body pain and physical component summary. So to sum it up, organ damage accrual impaired health-related quality of life in primary APS patients. What about the patient's perspective? In this cross-sectional survey of 270 members of the Hughes Syndrome Foundation, let me say that the 3 self-reported APS-related issues that impact health-related quality of life were pain and fatigue, lack of healthcare professional education and public awareness regarding APS, and medication unpredictability and fear of side effects. So we need to listen to our patients. From a philosophical point of view, what is the meaning of life? Quality of life, what is life? Because this is a subjective, individual, and intimate concept. So the patient's understanding of a life may be different from healthcare professionals' view. Let me say some words about syndemics. The syndemics concept involves the clustering of 2 or more diseases within a population, the biological, social, and psychological interaction of those diseases, and the social forces that precipitate disease clustering. The first model of syndemics was developed by Mary Singer in the 1990s and was about the interactions among substance abuse, violence, and AIDS. So syndemics is much more than a synonym for comorbidity. Syndemics rely on context. The hallmark of a syndemic is the presence of 2 or more disease states that adversely interact with each other, negatively affecting the mutual course of each disease trajectory, enhance vulnerability, and are more deleterious by experience inequities. Very recently, attention was drawn to the syndemic to explain treatment failure in inflammatory arthritis, because links exist between comorbidities, including physical and mental illnesses, driven by social, environmental, and economic determinants. So the syndemic approach takes into account the social context, the biocultural disease interaction, and socioeconomic characteristics. So I would like to ask you, in APS, it is time to put on our syndemic eyeglasses. I sincerely think it is time to do so, because we need to look at the limited access of healthcare our patients have, the quality of healthcare, the physical comorbidities, the mental or emotional comorbidities, and the social factors that are known as the social determinants of health. This is conditions in which people are born, grow, work, live, and age, and the economic, social, and political systems that influence their daily life. I have thought if these risk factors could be considered syndemics or only risk factors, and these are diabetes mellitus, hypertension, obesity, smoking, and depression. Because not only poverty, malnutrition, but also diseases of affluence, for example, food excess, contribute to these risk factors. Just to remind you, 20 years ago, Erkan and his collaborators showed that hypertension and smoking were thrombotic risk factors in APS, especially for arterial events. Very recently appeared this observational study about the impact of cardiovascular risk factors in APS, and it comes from the Spanish National Registry that included more than 5,000 hospital admissions, in which 12% of the admissions were because of thrombosis, with 7% of deaths. So as you can see here, hypertension, high cholesterol, and a smoking habit were prevalent among these patients, especially patients with arterial thrombosis. So we cannot minimize the impact of cardiovascular risk factors in APS. There is a high prevalence, but a low therapeutic target attainment. We have the global antiphospholipid syndrome score for risk stratification that has clinical utility, and this includes hyperlipidemia and hypertension. And there is also in the literature a GAPS cardiovascular disease obtained after adding obesity, smoking, and diabetes. But this last instrument needs to be validated. To end my presentation, I would like to say that our pending agenda regarding health-related quality of life in APS is vast. We need to identify barriers or problems to improve prevention and treatment in our APS patients. We need to explore health access, the quality of health access. Also, we need to promote anticoagulation clinics, and of course, education is very important, and not only the general public education, but also education to the health workers. And for sure, we need to develop a specific antiphospholipid syndrome health-related quality of life instrument. Only then our patients will have a better health-related quality of life, a better quality of life, a better life. Thank you very much for your attention.